วิทยากรนะครับดรโทโมอากินัตสึกาวะนะครับในการที่จะบรรยายนะครับเรื่องของการที่เราจะอพยพนะครับเมื่อเกิดภัยพิบัตินะครับโดยเฉพาะทางแผ่นดินไหวเนี้ยอย่างไรบ้างนะครับนัตสึกาวะเซนเซ
はい。
はい、こんにちは。
こんにちは。
こんにちは。สวัสดีครับ so I already introduced you to all the participants. I would like to invite you to give us your experience and sharings. How do you do the hospital evacuation during the disaster? Please.
โอเคสวัสดีครับชื่อฉันคือ Tomoaki NATSUKAWA. I'm an emergency physician in Japan. I'm a member of Art Project. My friend Dr. Pumin and Dr. Prashid invite me to this seminar. Today, I will share key lessons from Japan on hospital evacuation during disasters. From earthquake to floods, Japan has faced many challenges, and these experiences offer practical insights for healthcare professionals worldwide. Let's explore how hospitals can prepare, decide, and act effectively during the crisis. So, introduction, as you can imagine, disasters can damage hospitals directly or render them unable to continue care due to power outage, water loss, or isolation. In Japan, hospital evacuation became necessary during major events like the 2011 Tohoku earthquake and 2018 West Japan floods. Understanding when and how to evacuate is vital to saving lives and maintaining medical services. So, a purpose of this presentation has three goals. First, to share lessons from Japan disaster responses. Second, to provide concrete and practical guidance for hospital evacuation. And third, to support disaster preparedness for hospitals in Thailand. So as for when to evacuate a hospital, hospital evacuation should be considered when the building is unsafe, critical lifeline like electricity or water are cut off, and environmental threats like tsunami or radiation are present, or when resources like staff and medicines are exhausted. Among these factors, when the building is unsafe, emergency evacuation absolutely necessary. These factors often overlap and must be assessed quickly and carefully. So multiple triggers for evacuation. In real scenarios, multiple risk factors often occur together. For example, during the 2016 Kumamoto earthquake, hospitals faced structural concerns, water outage, and functional failures all at once. This led to the full evacuation of 10 hospitals. Timely recognition of these overlapping triggers is essential. Triage and prioritization in evacuation. Not all patients can be evacuated at once, so triage is critical. Priority should be given to those needing life-sustaining treatment or who cannot walk. Patients who are stable and mobile can be evacuated later. Daytime evacuation is safer, and clear communication among staff is essential. Proper triage ensures safety, dignity, and efficient use of resources. Additionally, all our patients are classified along mobilities such as stretchers, escort, and independent at admission in Japan. So as for on-site leadership and coordination, in a chaotic situation, clear leadership is essential. Set up an internal command center with designated rules. Quickly collect the triage data and share it across all departments. Coordination with DMAT like a Minimart in Thailand or other external support team is crucial for smooth operations. As for building a transport system, a hospital must secure safe destinations for patients, sometimes for outside the disaster area. Use a combination of ambulances, helicopters, boats, and even buses. Match each patient's condition to the most suitable transportation method. For example, helicopters for critical care and buses for stable patients. As for role of DMAT and coordinators, during disasters, DMAT and medical coordinator play a critical role. They assess hospital needs, assist with triage and transport, and help match patient to facility across regions. Their presence help overwhelmed hospital make coordinated decisions. So communication and tracking. Communication is a lifeline. When phone line go down, use radios, satellite phones, or cloud systems. Assign a liaison to keep track of all patients during transfer. Maintaining data and contact with receiving hospital prevents loss of information and supports patient safety. So, success case one, Kumamoto earthquake. So let me walk you through what happened in the 2016 Kumamoto earthquake. It forced 10 hospitals to evacuate. Over 100 patients were safely transferred using DMAT, helicopters, and coordination with neighboring prefectures. Notably, there were no deaths among the evacuated patients, and many later returned after hospital repairs. Next, success case 2, West Japan floods. Let me walk you through what happened during the 2018 West Japan floods. Mabi Kinen Hospital became isolated. Over 300 people, so patient and medical staff, including a patient and a staff, were evacuated using helicopters, boats, and high-tech vehicles. No lives were lost, showing how well-coordinated action can save lives. So additional examples, other cases include the Osaka earthquake in 2018, where 16 critical ill patients, ICU patients, were quickly transferred. It was coordinated by prefecture medical coordinator. And Ishinomaki Red Cross Hospital, which continued functioning despite damage during the 2011 disaster. Sometimes staying and continuing care is also the right choice if the conditions are met. So let me share key challenges we faced. Evacuation can be dangerous. At Futaba Hospital, Tohoku earthquake in 2011, dozens of patients died during the evacuation. Most of patients are aged over 85 years old. Staff shortage, confusion, and poor access to medical records made the situation worse. These are risks we must address through preparation. So, I want to share benefits of hospital evacuation. When evacuation is done properly, it saves lives. Patients are moved to safer environments where care can continue without interruption. It also reduces the burden of overstretched staff and allows for better regional coordination and use of healthcare resources. And the other side, let me share risks of hospital evacuation. So evacuation also carries risks. Patients may deteriorate during transport. Communities may temporarily lose local medical services. It also demands enormous resources, and it can impact hospital negative impact finances. So to summarize this presentation, here are 5 key recommendations. First, prepare in advance. Structure, surprise, plans. And second, share evacuation criteria within the team. The third, plan with patient needs at the center. The fourth, coordinate early with outside agency, with DMART, Interan, Minimart, Mart, so PHEOC, like that. And fifth, continue to support regional health even after evacuation. So final message, hospital evacuation is never easy, but it can save lives. With the right preparation, coordination, and the leadership, we can turn disaster into resilience. Let Japan lessons help strengthen your system and protect your communities. And if you plan to construct a new hospital, be sure to build it in a safe location with earthquake resilient design. Also prepare backup lifeline such as electricity, water, gas, and fuel for at least 3 days. In Japan, we have disaster-based hospital this hospital have such kind of function of storage, common cup. Thank you.
Natsukawa Sensei, thank you very much for your concept and your experience about hospital evacuations during disaster, both earthquake and flooding. Our participants have some questions. The first question is, do you have any recommendations about the equipment for evacuate the patients in the building that over 10 floors?
Yes. So when the earthquake happened, we cannot use the elevator or some machine. So we should transfer the patient by our hand stretcher, but stairs is not easy to transfer the patient by stretcher. So we have some stretcher made by the cross, and so many hospital prepare the stretcher made by cross, so it can make us help us to transport the patient by stairs.
So you mean that we have special equipment to transport the patients on the stair, right?
Yes.
Okay, so most of the hospital, they are risk for the earthquake, or do the hospital evacuation need to prepare that equipment?
Yes.
And the second question is, both of us, even the hospital personnel, the patients and relatives, when the earthquakes, especially in Thailand this time, we are panicked. How do you deal with that?
Pardon me, last word.
We got panic.
Yes, yes.
How do you deal with that, or how you manage?
Yes, yes, yes. In Japan, we have many earthquake, not so big earthquake. So Japanese often not become a panic, but in Thailand, very few experience for the earthquake. So I think you were surprised, I think. But in Japan, we believe the magnitude under 6.0, the building is safe, we believe. So we don't become a panic. But if the very big earthquake over magnitude 6.0, so we are educated from elementary school. So the first we protect our head from the some things dropped to us. So we go to under the desk and protect our head. After the shaking stop, we have some alarm system in each building. So please go to outside from this way, or using not using elevator, using the steps, and go to designated place. And if the building is not collapsed, so tend to collapse, stay in the building. So in hospital, we have critical ill patient like ICU. So if the medical professionals, all medical professionals go to outside, patient is risky. So they receiving so ICU care. So some medical professionals stay in the ICU and continue to care the patient. Okay.
Okay. So you mean that you have the structure that can tolerate over 6 Richter scale of the earthquake, and also you have the protocol to evacuate, and also the most important that you educate every people in Japan about the earthquake and how to do that, right?
Yes.
So to get rid or to decrease our panic, you need to be educated.
Yes.
Okay. And for your experience and of your sharing in Kumamoto earthquake, there are 8 of 10 hospitals that evacuate. The problem is, why not 10 hospitals all evacuated, or when the hospital want to evacuate it, who decide or who make the decisions about that?
Yes. So I know the one hospital case I related to the evacuation. So the director of the hospital said to the medical coordinator of the prefecture medical coordinator, we want to evacuate. And medical coordinator sent 6 or 7 DMAT team to the hospital and evacuate the patient with DMAT, medical staff in hospital and DMAT. So decision making by hospital director, and hospital director communicate with the coordinator in the of the prefecture. So prefecture send DMAT team to the hospital.
And before the hospital director can make the decisions, do they need any information from the engineer to evaluate the hospital structure before, or they have the protocol already?
Yes. Hospitals in Japan should have a business continuity plan, BCP, and each hospital have its BCP. So in BCP, some person in charge of estimation evaluate a building. They should evaluate the hospital unsafe or not, tend to collapse or not, and if the hospital is unsafe, they communicate with the hospital director, and hospital director decided. So in my experience, so major crack in the major pillar, we should report to the director, and we should evacuate the building. But if the crack in just a small wall, or we don't see the crack in main pillar, we evaluate detail.
Oh, so it seems like your hospital personnel can evaluate by yourself first, and
yes.
and then you have the reporting system that you can report to the hospital director, and
yes.
if it is unsure, you will have the evaluation team to evaluate that damage, right?
Yes. So we have a checklist in each ward, each admission word, so we can check so wall, pillar, water, electricity, and check yes, no, unclear. So check, and report to the director within 5 or 10 minutes.
Mhm. Oh, okay. And it is so many questions. You still have a time, right?
Yeah,
Yeah.
I have.
Yeah. Our people are very interesting. And there also some questions associated with the Kumamoto case. There's what is the biggest challenge in coordinations from the multi-agency during the hospital evacuation?
So we have some challenges in Kumamoto earthquake hospital evacuation. The first one, the safety for the DMAT is very difficult to estimate. So some DMAT didn't want to go inside the hospital. So medical staff in hospital bring the patient to the first floor of entrance of the hospital, and DMAT bring the hospital to other hospital. So it is very difficult to evaluate the safety of the DMAT. It's very difficult. And the second, some hospitals don't have the triage system for admission patient, so they cannot prioritize the patient. So who is the first, who is the second? So it is some confusing. And the third, that's a financial problem. So if all patients go to other hospital, this hospital cannot run the hospital, so they cannot earn money. So governmental support for the hospital is needed. So hospital evacuation for the hospital director, hospital owner is very, very difficult decision making. I think the three challenges we had.
Okay, thank you. And there are another questions about the hospital evacuations. From your slides, you mean that the first priority is the critical patient, right?
Yes.
So the question is how you prioritize the patient who need to evacuation first, and the second, where you will evacuate.
So prioritization of the evacuate. So if the electricity stopped, ICU patient should be evacuated by medical professional first. If the building is unsafe, so tend to collapse. So all patients should be evacuated quickly. So in Japan, we classify patient. So move by stretcher, move with escort, move by themselves, and in admission. So if the disaster happen, we medical professional go to the patient who are using the stretcher or who needs escort to evacuate, and evacuate these kind of patient with medical staff. And if they can go by themselves, uh, uh, we make some loud voice or microphone and go to go outside of the hospital. So that's our prioritization, not clear. And And next, the where to evacuate. So the first evacuation place, we decide in BCP. And for example, regarding our hospital, evacuation hospital, first evacuation place is the car parking lot. So in uh, uh, far from the building. Uh, so if the building 30 meter or 40 meter, so we should apart from 30 meter or 40 meter from the building. So we decide the first evacuation place in advance in BGP.
Okay. So you mean that is it necessary to include in our VCP?
Yeah.
We need to prepare for the our hospital evacuation plan, right?
Yes, each
and
hospital should decide it.
yeah. So your priority is for the most critical patient and the less critical one and the ambulatory one to evacuate.
Yes.
And is there any challenge, especially in Kumamoto, that you do the hospital evacuation for all 8 hospitals in the same time? Is there any challenge to do that?
Once again.
Yeah. Like in Kumamoto, 8 of 10 hospitals evacuate, and in Thailand, at that time, all of the hospital we evacuate all the patients down to the ground floor, and in some hospital they did the operation at the parking lot. So is there any challenge?
So in Japan, so when the Kumamoto earthquake, the evacuation time is night time, so we have no right in the parking lot and or aisle to the parking lot. So many medical staff or patient went to the parking lot carefully. Some patient lie down on the road. So it is a very big challenge, and so we cannot count the patient or medical staff in dark atmosphere. We cannot evaluate all the patient or all the staff had evacuated yet or not. It is very difficult to evaluate.
Yeah. And another question is, what type of communication that you use during earthquake or any disaster? It's because sometimes we cannot use our internet or our mobile phone.
Yes, it's a very challenging matter, I think. So, we cannot use the mobile phone or internet in the disaster area. So now, my experience, recent experience in Noto Peninsula earthquake last year, and last year, Vanuatu earthquake in South Pacific country. So we used air Starlink by the so that's a very, very good communication tool. I don't like Elon Musk, but Starlink is very useful. So we can use Starlink. We can see the YouTube, not stopping the movie. So it's a very, very good device, I think.
Oh, so if we don't have any other means of communication, you can use the satellite.
Satellite, yes.
Okay. So I I think that is all of the question from the chat, but I would like to invite all of the participants who would like to ask the question to Dr. Natsukawa. Who want to ask any question, please? So there are still a question on the chat that how to decide or evaluate to re-entry into the hospital.
Yes, if the hospital evacuation are performed, the specialist for the building evaluation check detail wall, pillar, some facility, and if the specialist say we can use this building, patient, firstly, medical staff back to the hospital and check detail by medical in the side of in the point of the medical care, and after that, patient come back to the hospital.
Okay, thank you very much. That is almost all the questions from the chat, and probably any participants have any questions ไม่ทราบว่าใครมีคำถามเพิ่มเติมไหมครับ so it seems like there are no questions about your experience about the hospital evacuation in Japan. So on behalf of the Thai people, I would like to thank you very much for your time. It is very valuable information and valuable experience, and that we can use to prepare ourselves in the future for the earthquake. Thank you very much.
ขอบคุณครับ